Welcome to the Glucocorticoid Impact Working Group. Thank you for taking the time. My name is Catherine Hill. I'm one of the co-chairs of this group. This video aims to give you some further background to the extensive group work that we've done as part of this working group. If you haven't already, we would suggest you also view the glucocorticoid work whiteboard overview.
Thanks, Catherine. So my name is Jonathan Shear, and I'm one of the fellows for the Glucocorticoid Impact Group. So to set the stage, we know that glucocorticoids have been used in inflammatory diseases for many years. While they are effective, and we recognize a number of effects of glucocorticoid therapy, such as increases in blood pressure and increases in blood sugar, there are aspects which we have not been as good at recognizing, especially those which are most important to patients. This is increasingly important as a number of steroid-sparing agents are being developed, and we need to be able to assess the benefit and risk of these agents compared to glucocorticoids with our patients in mind. This gap in knowledge has been highlighted previously, including in this position paper from EULAR in 2016, that includes the statement that high-quality data on glucocorticoid harm are limited, and study results are often contradictory, have a high risk of bias, or are evaluated inconsistently. With a future research agenda for glucocorticoids, including standardization of questionnaires and glucocorticoid-specific core outcome parameters for all clinical trials. Therefore, starting at OMRAC 2014 and over the next 2 years leading up to 2016, the following aims of the group were created. Firstly, to define a research agenda in the context of previous and ongoing work on medical monitoring of glucocorticoid effects, and secondly, to follow the OMRAC process of core outcome set creation and subsequent instrument selection. So you may ask, what about the Glucocorticoid Toxicity Index, a tool to be used by clinicians in clinical trials to measure adverse effects of glucocorticoids? While it does include a number of pathophysiological manifestations, it maybe does not cover life impact as prominently and was ultimately based upon the consensus of just 19 clinicians and also did not include any patients at any stage of the development process. Therefore, we see our work as complementary and adding additional value to the understanding of this area in general. Here is our working group, and we're especially grateful to our patient partners, namely Pamela Richards from the UK and Susan Beard from Australia. Now, we'll give you a quick overview into the work, literature reviews, qualitative work, and surveys that form the first part of the process leading to domain set creation. A number of literature reviews have been conducted, including, firstly, to look for any already validated patient-reported outcome for the use of systemic glucocorticoids across multiple conditions. No validated patient-reported outcome was found. Secondly, to look at what adverse effects were reported in randomized clinical trials of glucocorticoid use in polymyalgia rheumatica, rheumatoid arthritis, Crohn's, and ulcerative colitis, of which there were 63 effects in 11 categories. For example, under ocular were glaucoma, cataracts, blurry vision, and dry eyes. And finally, thirdly, to identify patient-reported effects from quantitative, namely surveys, and qualitative studies, which yielded 71 outcomes in 4 categories, with data from the qualitative studies really enriching our knowledge in this area. In addition, there was also some original survey data from 2 centers. In Australia, across a number of rheumatic diseases, and in the US in rheumatoid arthritis patients. Patients were asked about the frequency of 19 impacts of glucocorticoid use, as well as which was the worst. The light blue refers to the overall frequency, the most frequent being sleep disturbance, and the dark blue refers to the frequency of the effect being described as the worst, with the worst being weight gain. However, when you do flip the questions and ask how much they felt that glucocorticoids helped their disease, the majority stated that it had, and also the majority stated that they felt the benefits had outweighed the unintended effects. In terms of the qualitative studies, there were 4 separate studies across 96 patients for this part of work. 14 in Australia in giant cell arteritis and polymyalgia rheumatica. For ANCA-associated vasculitis, 50 patients from the US, Canada, and the UK. For rheumatoid arthritis in the US, 11 patients, and for lupus and myositis together, 21 patients from the US. Each of these qualitative studies focused on the patient's experience of glucocorticoids and the impact, both positive and negative. The following 4 themes emerged throughout the qualitative work. Firstly, that glucocorticoids are beneficial, and for some, the fact that they are beneficial means that they are often necessary to be able to get on with life, despite potential adverse effects, such that there is often a decision to be made in terms of having to balance the benefits and risks of glucocorticoid therapy. In addition, there's also a question of attribution, So are the perceived effects related to the glucocorticoid, related to the underlying disease, or related to something else? And here I'm going to turn over to one of our patient partners, Pam Richards, to tell us a little bit more about her experience of glucocorticoids in this context.
Hello all. Hi, I'm Pam Richards from the UK. I have a number of health conditions which require glucocorticoids at times, including rheumatoid arthritis, scleritis, and vasculitis. I can concur with everything that Jonathan has said that's come out from the evidence. As a person who has used a variety of glucocorticoids in the past, and also my sister who heavily relied on them, I have a lot of experiential knowledge of the benefits and also the side effects. I have a love-hate relationship with steroids, as I call them. They're a fantastic drug. They really are a great help when I need them, and they get me through really bad patches and also enable me at times to enjoy a really good day when I wouldn't have necessarily had a good day. But there are also long-term adverse effects which just stay with me and sometimes feel intolerable. And I'm really surprised that after over 80 years of glucocorticoids being available, we still haven't got to the point where we can assess how the patients really feel about taking glucocorticoids. We know that they are beneficial and we know that there are adverse effects, but we've never really looked at how the patient feels about this. And I'm really excited that OMERACT, through Jonathan and Catherine and the team, are taking this issue really seriously. Thank you. Thanks, Jonathan.
Great, thank you, Pam. So following on from all of this work, the literature reviews, the survey, the qualitative work, the working group came up with its list of candidate domains from which to seek agreement about what should or should not make it into the final core domain set based upon the modified Delphi process. So for round one, there were 4 overarching categories: physical symptoms, psychological symptoms, participation, and contextual factors, in which the 63 candidate domains were housed. For round one, we had a total of 295 patients and 68 clinician researchers complete round one, and this is the distribution of where the patients came from. The Delphi was conducted in English and was not translated to the other languages, and was administered rounds 1 to 3 via Delphi Manager. So I cannot list all 63 items, but here are the top 10 by each stakeholder group, patients and clinician researchers, with the value in the right-hand column representing the proportion of individuals in that stakeholder group identifying the specific outcome as critical, i.e. a score of 7, 8, or 9, to be measured in future clinical trials involving glucocorticoids. Those that are highlighted in red met the OMERACT definition for inclusion in a core domain set, so greater than 70% agreement in each stakeholder group, listing the outcome as critical: bone fragility, diabetes, infection. In addition, respondents in this group, in this round, were allowed to free text in additional outcomes which they felt were important but not represented in the original 63, such as sweating and sleep apnea, so pathophysiological manifestations, issues relating to returning to the pre-morbid state, making the condition noticeably better, being able to resume work, functional independence, and then things related to the doctor-patient relationship, confidence in your treating physician, and ensuring patients are fully informed about adverse effects of glucocorticoids. These were added to round 2, and again, these list the top 10 by stakeholder group. Again, those in red met the greater than 70% agreement that these outcomes were critical in each stakeholder group. So now we have bone fragility, diabetes, infection, and additionally high blood pressure and eye problems. As you can see, a number of the outcomes related to the doctor-patient relationship for patients was deemed very important, but not deemed as important by clinician researchers. Additionally, there were a lot of outcomes that were close to the OMERACT definition for inclusion, but not quite. So in the process of discussing the transition from round 2 to round 3, given that we will eventually be proposing 5 to 10 items for inclusion in that final core domain set, there was a recognition that we needed to cut down the number of current domains in order to focus and prioritize. As mentioned, there were 5 or so outcomes emerging at 70% agreement, but there were also very many that were close to threshold. And those close to threshold were a lot that came out in the qualitative work that Pam just referenced. And so after discussion at ACR 2019 with the working group and the wider OMRAC community, it was decided to go through each outcome in turn to assess these questions and additionally assess and additionally remove those where there was less than 30% agreement that the outcome was critical in both stakeholder groups. So some items for consolidation included increase in appetite, weight gain, and changes to diet, skin changes and bruising, and then questions about were these outcomes true effects of glucocorticoids or not were things like confidence in your treating physician and not being taken seriously by health professionals when experiencing potential side effects. So for round 3, this was slimmed down to 32 outcomes. Again, the top 10 by stakeholder group are listed, and again, those in red met the greater than 70% criteria in both stakeholder groups for being critical to a measure in every clinical trial. So now we have bone fragility again, diabetes again, infection again, high blood pressure again, eye problems again, and now in round 3 added osteonecrosis and making the condition noticeably better. Taking a closer look at those outcomes which were ranked as important but not quite meeting the thresholds for inclusion, it again was recognized that a lot of these outcomes were very important to patients from both the combined work of the literature review, the qualitative interviews, and the survey studies. So items such as weight gain, depression and low mood, fatigue, sleep disturbance. So given the fact that we wanted these represented in the core domain set since they'd been so prominent in that initial foundational work, it was decided to proceed to a final round or ranking survey to further understand how important these outcomes are. So round 4, this round invited everybody that had originally registered interest, regardless of completion of the original 3 rounds of the Delphi, as well as in addition to additional patients from the same patient groups that had originally been invited. Initially, patients and clinician researchers were first asked to comment if they agreed that the items that already reached consensus by agreement at the end of round 3, bone fragility, diabetes, eye problems, infection, high blood pressure, and osteonecrosis were truly important to be measured in clinical trials involving glucocorticoids. As you can see, all patients voted yes to this, and 98% of clinician researchers voted yes to this. Subsequently, patients and clinician researchers were then asked for the following 19 effects or outcomes of the above effects, which if any should be measured in every, some, or never in clinical trials involving glucocorticoids. So these were the items or the outcomes that didn't quite meet the OMRAC threshold of the 70% in each stakeholder group. So these are the percentages of those who responded that this item or outcome should be measured in every clinical trial. Again, as you can see, there was a lot of discrepancy between patients and clinician researchers, and at times quite marked discrepancies, including greater than 10%. So after further discussion, it was agreed that utilizing agreed OMRAC methodology, additional analysis on the results would be performed, including weighting the responses from each group based upon the responses and the number of participants. And we decided upon finally including outcomes for the final domain set, where the weighted proportion was over 70%, as long as there was at least 50% agreement in both stakeholder groups. So fatigue, sleep disturbance, weight gain, increase in appetite, and depression or low mood made it through to our consideration for the final core domain set. And these were exactly the outcomes that were highlighted strongly through that initial qualitative work. So this leads us to our proposed core domain set for clinical trials, including the use of glucocorticoids, for which the inner core includes infection, bone fragility, hypertension, diabetes, weight, fatigue, mood disturbance, and death. So although osteonecrosis and eye problems met the OMRAC thresholds for being included in the mandatory group, due to concerns about eventual feasibility, these were placed in the middle core. Thank you for listening and reviewing this information with us. Please post your questions, comments on the discussion board, and we look forward to continuing the process at the live workshop on October 20th. Thank you.